So welcome everybody to SEVA VentRounds. Today is October 14, 2025, and we're gonna look at a couple of cases which we call blinded by the light. So I would ask you to look carefully. These are interesting in many different ways. In terms of disclosures, there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And there are my and Rob's conflicts of interest, which are disclosed because this is a CME activity, and also we offer CRCE. This is a recorded session, so keep your microphone muted, but if you want to interact with us, just unmute it and please go ahead. Or if you are shy and don't want to talk, just put it on the chat function. We have control over both of them. There's CRCE for our respiratory therapists, and so just do remember to fill up the evaluation within 1 hour of completion. And I thought that sometimes it is just going back to basic principles. And I would ask you to recognize that when you're looking at waveforms for mechanical ventilation during inspiration, if you're in a PC pressure control as a breath control variable, look at the flow waveform during inspiration. And if it's volume control, then look at the pressure waveform. This is key. That's where your eyes should look. And then during expiration, so in the expiratory phase, look at the flow waveform. And the reason is because we're controlling the pressure. So your eyes should go and look at the flow. Roberto, any thoughts?
No, that's a very basic rule of thumb.
Very basic rule of thumb that sometimes we forget, and we fall on our biases of looking at some other place. So I would just remind you of that this should be a t-shirt, a SEVA t-shirt to say, look at the flow, baby. All right. All right. So we're going to get started with this case. And so in our usual fashion, the first thing is, what is the tag? And so I'm waiting for the chat to see.
There's a response.
All right. And Alicia grabbing the front, and it just starts coming through. Excellent. And I mean, for this case, we're not even hiding anything, right? We're keeping all the information. So we give you here the mode for this ventilator. This is a servo U, and it's PRVC, recognizing that PRVC may not be the same mode in other ventilators. So even though they have the same name, they may have different tags. But what this is saying, that this is PC CMB A. And what that means is that we're controlling pressure during inspiration. And so the flow depends on the PMOS resistance and the elastic loads. CMB, which means that all breaths are mandatory, meaning that they were triggered or cycled by the ventilator. And A for adaptive, which is the targeting scheme and talks about we set a target tidal volume, and the ventilator will adjust the pressure, the inspiratory pressure, to achieve that. Rob, thoughts?
Just a reminder that that's not a tidal volume like in volume control. It's an average over several breaths.
I love that you're highlighting that, because just looking at it, we have set the tidal volume at 370. And if we come to this corner, and when you're taking care of any of these ventilators, you should know everything that is appearing on your screen. And you can see that the exhale tidal volume and inhale tidal volume are above. not by much, by around 40 cc's, but they are higher than the target. Right. Very good. So the next question is, during inspiration, what's the load? All right. There's a rapid response from the team stating that during inspiration, there's PMOS. And you're absolutely right. PMOS is the driving force here. And the way to recognize this, that this is PMOS, it summarizes in one word, which is you have to memorize the passive waveform. And the passive waveform doesn't look like this. The passive waveform on pressure control looks like that and has an exponential decay. And so everything that you see up here is high quality PMOS. So absolutely. And during expiration, what do you guys think? So I see PMOS. Anybody has a discordant thought there? So let's take a look carefully to this. And one of the tricks is that there is one condition that is occurring here that we're going to talk later about. But if you look at the expiratory waveform, it doesn't look very pretty. It doesn't look very, very, very nice. It starts going down, and then there has these oscillations up and down. And I like to look at the volume because the volume amplifies. It's exactly the same waveform, but amplified because the scale is very different. The other one is flow liters per minute. This is in milliliters. So it's easier to see the aberrancies. And you can see that the time constant is prolonged. It takes 1, 2, 3 seconds to get to baseline. And over here, it's at least 1, 2, and then there's this oscillation, so it becomes a little bit harder. The second is that these oscillations are identical from one breath to the other. If you notice this oscillation here, this approximation to baseline is identical to the next one and identical to the next one. So very similar, which makes me, I mean, could it be PMOS? Possible, but the way that the exponential decay is going down and with these oscillations, it makes me more sensitive to whether this is a cardiac oscillation involved there. Roberto?
Yeah, I just wanted to point out when you're looking at the inspiratory load, somebody might be tempted to look at this dynamic compliance in the lower right-hand corner and say that, wow, that's a huge compliance. Well, there's two things about that. First of all, it's way larger than you would expect because most patients on mechanical ventilation have compliances less than 60 or 70. And the other thing, it's got an asterisk, which tells you that it's a questionable number. And the reason why it's questionable because you got PMOS during inspiration. So the ventilator doesn't know how much pressure to use to calculate the compliance.
Yeah, so for the amount of pressure that it's giving, in this case, the patient is a PEEP of 12, and I presume that the inspiratory is around, I don't know, 5 or 6, 50, so 15, 16, because the end expiratory pressure is not, the peak pressure is not what the patient is getting. I would say that the pressure that the ventilator is giving is around, I don't know, 6 mLs per kilo for the amount of tidal volume. That's where these very large values are coming. Yeah. So there's a question here, Rob. Could we potentially rule out PMOS during expiration because it's not really deflecting from the baseline? So it's not going, I guess that when you say deflecting, Alicia, you mean that it's not getting to it?
It's not, so when there's true PMUS, it's not coming down and then going back up to baseline.
Mm,
It's pushing away from.
like that.
Yes.
Yeah. So
Well,
that's
that depends on what kind of PMUS we're talking about, right? You're talking about expiratory PMUS. Those little humps towards the baseline could be inspiratory
It
PMUS, right?
could, yeah.
excellent. Good thought process. I'll show you more evidence in a second, but you're right. Usually when we think that there's PMOS, it's a little bit more tonic, but sometimes the patients can relax and continue to go. And so you get these little divots of relaxation. So it's suspicious for us. Yes, Megan, we're going to talk about that in a second. But the expiratory, these oscillations that we see here are very regular. So those are just for you to consider, and I'll show you what we did in a second. But so the expiratory, I would say that it's resistive for us to discuss. I also want to highlight that during inspiration, the flow actually looks sinusoidal, which would be what I would expect to see in a patient breathing spontaneously. So just keep that in the back of your mind. All righty. So any PV discordance that you say. So well, let's start with the trigger. So write it down, have no fear. Anybody? Okay, I see Ariel has put. Yama says normal. Couple of normals. More normal. I love this. And this, my friends, is why we're together today here. So let's take a close look at life and the pursuit of happiness. So I'm gonna make it very big. Okay. Who's triggering the breath? Yeah. All right. So we are in alignment. You have said it's the machine. And we know that because, well, the only device that know that is the machine, because it's using the signal, and it will signal us if it's the ventilator. And in this case, there is no change in color at the beginning of the trigger, and this is by flow, so we would expect a change in the flow waveform, and sometimes this ventilator does it in the pressure waveform, I don't know why. But so you have a machine trigger breath, and it's followed by PMOS. You told me, I didn't say it, you told me that there was PMOS on this case. So what trigger issue does this patient have?
Yeah.
Yeah.
Megan says early.
Yeah. So Ariel said it with a question mark, but this is without a doubt, a very hidden, very nice early trigger. So the point being here that remember that right now there is some, as we are learning more about what reverse trigger means, which is a form of early trigger, it can happen at the beginning, in the middle, at the end of inspiration, and actually, and even though this is a little bit, I mean, it's difficult for us to categorize. It can also happen at the early phase of expiration, the way that we are describing it right now. So it's important for us to just recognize that this is an early trigger. But it's the most beautiful early trigger that I have seen, because it's practically undetectable. The only reason we know it is because it happened through mandatory, because there was a mandatory breath. So just remember that once that you detect these early trigger, you essentially, the rest don't matter, but in this case, there's evidence of assistance. So there's work shifting. This is work shifting. And as Megan highlighted, there is evidence of PMOS right here. So if you this should look like that. And then it would have made it easier for you to detect that. So there's a question. It says, doesn't the early delayed rise in airway pressure with an upward slope suggest? Yes, it's so that absolutely, Steve. So there's aberrations on the pressure waveform that can suggest that there's PMOS. It's not necessarily inadequate inspiratory flow. That's a something that we have discussed in the past, in which the patient is getting as much flow as it needs. Actually, the pressure is above the baseline. So it just means that there is evidence of PMOS, not of inadequate flow. And that's why we think that the term flow asynchrony or flow starvation for these abnormalities is not the right term to use. It just simply means that there is evidence of PMOS. But you're absolutely right. The pressure waveform shows abnormalities. Now, because you're controlling the pressure, some ventilators are much better at controlling the pressure, and you may not see that. So that's why we teach you to see at the flow rather than the pressure. Roberto?
Yeah, the upward rise at the end of the pressure waveform represents the patient's PMUS relaxing and the ventilator flow catching up.
Yeah, so and actually this is a good example of I mean, if you would consider that there's still PMOS here, right?
Sure.
So definitely it's relaxing. I mean, it's doing less effort than before, but it's still pretty active. So that's why this big at the end, it's also hard for me to follow that as a late cycle, which that's how most of the literature recognizes it. Yeah, exactly, Ariel, exactly. But the flow doesn't lie. And that's why your eyes look at the flow.
Right.
Your eyes look at the flow.
That's a good way to explain it, Ariel.
Yeah. So what we did for this patient is we did an end expiratory pause. And this is very useful, especially in this case, for many reasons. The first one is that when we do the end expiratory pause, if there was expiratory effort, I would expect the pressure to rise, and it's not doing so. So that's one of the items. The second one is that it allowed us to measure the POC. Anybody wants to tell us how much is the POC and how much is the PMOS, the estimated PMOS? So I'm going to put here the POC and here the estimated PMOS. And this is a topic that drives nuts my friend Roberto because of the signs. So if you want to put the number, and if you cannot see it on the screen, because I know, so the first one is the pressure before. Here's the cursor, and it says 12. And then at the nadir, the lowest amount was minus 13. So those are the two values that we obtained. Have no fear. There. All right. So Alicia already went all the way to the PMOS. And she said 18.75. And anybody measure the POC and you have a value? There you go, Fernando. But actually, it's a negative number. It's minus 25, Fernando. That's the important item here. Yes, thank you for putting minus. Roberto, you want to just guide the discussion here of why the signs are important here.
Yes, the signs are important. Well, first of all, just mathematically, POC is the change in the pressure during the occlusion. So to get the change, you get the pressure at time 2 minus the pressure at time 1. Pressure at time 2 is minus 13, and minus time 1 is minus 12. So minus 13 minus 12 is minus 25. Now, the reason why that's important is, and it was pointed out in the paper that described this, is that to convert to P mus, which is always a positive number doing an inspiratory effort, you have to multiply by a negative coefficient, and that coefficient is minus 0.75. So minus times a minus is a positive, and if you don't get these things right, you won't get the right number.
Thank you, Roberto. Questions to Roberto about this? I didn't put us here. Yeah, it's a not announced block. Thank you for saying that. But you can see that this patient was generating a fair amount of PMOS during that inspiration. And to me, this was also an eye-opening or an important point, is because there is no doubt in my mind that there's a lot of PMOS because this is sinusoidal, so it's overcoming everything. But the tidal volume is not that far away. So if you had not done a POC on this patient to assess how much effort is happening during this early trigger that it's occurring in front of our eyes, you would not realize that it's generating a pretty significant amount of PMOS in this patient. Now, I don't know the clinical context because this happened a while ago, but it's relevant for us to recognize in every patient. First, that you have to look at the flow if you're controlling pressure, because that's where the truth lies. And number two, that a POC and end inspiratory pressure are key for all our patients. All righty. And now this is like the candy for all of you. So I'll give you the tag because there's no secrets on this one. This is volume control, CMBS, recognizing that it could be something else. All right. And then I'll let you look at the load and see what you think is the load during inspiration. Have no fear, enter your thoughts, release that thought. It's either elastic, resistive, or PMOS. Whichever you put, you have 30% chance of getting it. All right, a lot of love here. So let's think about this. All right, so remember, this is a descending ramp. And so that means that at the beginning, the flow is the highest. So that means that the resistive component should be the highest. So if the resistance is elevated, you should see the peak at the beginning in the pressure waveform. And then at the end, when the flow is the least, that's your elastic load. And so if you look at this, there's a very big step up, no doubt. But then it dissipates, and actually it ends up very rapidly on the in a flat essentially part. So I would say that, and unless Roberto, you have a different opinion, that this is elastic.
Yeah, also look at the dynamic compliance.
Yeah, it's in the gutter.
It doesn't get much worse than that for an adult.
Well, we had somebody with 6 the other day.
Wow.
Yeah, but actually we should bring that one. But and then during exhalation is a little bit off. There's something odd here. So exhalation, remember we control the pressure in exhalation. What's the load? elastic or resistive. Yeah, I like what you said, Ariel. Absolutely, the end pressure, so the peak pressure is 35. So that tells you that at least, if not accounting for out of peak, in this case, the driving pressure is very high. Yeah. So all right, team. So the load. So you can see this doesn't look the usual way. This doesn't look the usual way. So you see a component that empties relatively fast, right? It empties very fast in less than, probably even less than a half a second. You lose a lot of volume. And then suddenly it flattens out. It becomes short, the slope changes radically. And then it changes again. So this does happen. I mean, you can have two compartments, and these may look like you have a dominant elastic load, but there is a resistive load behind, and you may see this item here. Rob, you want to comment on this? Am I
Yeah, it
full of
looks like
prunes?
some kind of flow limitation, right?
Yeah.
And also the rapid increase in the end of the expiratory flow looks like a patient inspiratory effort, but it apparently didn't trigger. It wasn't registered as a trigger effort.
Yeah, that's what you so now that we have said that, I really like, so Roberto took a couple of steps ahead, and this is very good. So look at the patient ventilator discordance and tell us is there a trigger issue? Yes or no? What do you think is the trigger? Normal, early, late, false, failed? Stop asking, Eduardo. This is mechanical. Yeah, this is a very tricky one, my friends. Very tricky one, because I don't think that there is a good. I mean, we have not even put this in the book. So you see the flow comes out very fast, then it slows down, and then there is a change in slope again. And this change in slope is happening on and actually it crosses baseline. I'm gonna, let me see if I can make it bigger. Oh my God, yes, I can. Look at that. So it crosses baseline, which means that there is an inspiratory effort here, here. It's even more pronounced here. You see, and actually it's starting to finish. So it starts here and then probably ends around here. Look at this one. That's even more evident that the patient took a breath, or looks like it's very suspicious that there is the patient is trying to trigger, but the ventilator is going at 34 breaths per minute. 34 breaths per minute. So it's essentially, I don't even know how to mention this. It's a failed trigger, actually, of, if anything. It's a because it didn't trigger the ventilator. It's triggered by the machine. So it's just so aligned to it that it looks, I mean, it's essentially marching out one to the other. And it's kind of a reverse early trigger. So the opposite of an early trigger. But there's PMOS that is not triggering the breath. So this is technically a series of failed triggers, and then the ventilator triggers on its own. which if it was triggering the breath, then it would be a late. Yes, exactly, Steve. Yes, absolutely. You're right on. I think that there is a component of auto peep, and that's not letting the patient trigger. And so our team caring for this patient, I mean, there's no doubt that this patient is an extreme. I mean, it has a compliance in the gutter, very low tidal volumes, very fast respiratory rate, high oxygen levels. And you can see that they put a pressure trigger. And whenever I see a pressure trigger, it makes me think that something was happening that was leading to issues. So I would say my feeling is that this would be a failed trigger. And if the sensitivity was set appropriately, then it would be a late trigger. But under this, just by definition, it's a failed trigger. Very fast, the patient is going. But I cannot prove it. And the only way to prove it would be that Eduardo Mireles, when it looked at this waveform, had pressed the end expiratory pause. And guess what I did? Yes, I did not press it, Fernando. I failed miserably. Or if I did, I didn't record it. And so I apologize to all of you. This is I cannot prove that this is a failed trigger, but I think it calls the same message to all of you. You need to look at the right place to read these waveforms, because otherwise these two are blind to all of us. If you don't know how to read the waveforms, you would not see these. You would not see this. So
Eduardo, real
yes.
quick question. That the patient's trigger effort rate is the same as the set rate of the ventilator, for what we can see. You think that's some kind of entrainment happening?
Oh yeah.
That the patient's just not able to do it?
Absolutely. I think that's what when we were having the instructor class, we were talking about this, and in a way, I mean, it's going at the same rate. So is this because we set the ventilator so well, or this is a entrainment process that occurred? And so, yeah, absolutely, Ariel. You're speaking my T-shirt. An end inspiratory and an end expiratory pause recorded, and every ventilator check should happen because it has a lot of data. So I would just highlight that we saw a case of early trigger that was invisible to us unless you saw the flow waveform with the hat of looking at who triggered and is there PMOS or not. And then we saw a case of failed trigger that was at a rate that was entrained, that we failed because we did not do an end expiratory hold that we should have done. So I hope that this brings to you a couple of key messages about stopping by knowing where to look. So look at flow when you're controlling pressure, and look at pressure when you're controlling flow, and always do your 2 pauses. 2 pauses leads to happiness. Rob, any other words of wisdom?
Yeah, just one thing, going back to the calculation or the estimation of PMUS from the POC. The thing to remember is that's not the PMUS during that PR, okay?
Correct.
It's less than that because it's the estimated average PMUS during ventilation, which doesn't have to be as high because the ventilator is providing some P-vent.
Oh, that's, I love when you bring these moments of Zen. Absolutely. So you're calculating the PMOS for the prior breath.
For the prior breaths,
Yes.
during ventilation, yeah.
So here's the CME for all of you that want the CME and CRCE for those that want CRCE. I really appreciate your input and being part of the SEVA VentRounds. And I hope that you learned as much as we did, because every single one of them. Now, send us your waveforms. No waveforms, no happiness. So send them so that we can analyze them, and we'll give you your respective support. Now, next SEVA VentRounds is number 100. Next, well, it's not really number 100 because I think that we passed 100, but there's a couple that we didn't upload because we forgot to record. But technically, unless we forget to record it, next one is 100. So it will be a special edition SEVA VentRounds. So have a great day, team, and thank you very much.